2 of the MRCP. Our first lecture today concerns acute kidney injury and chronic kidney injury. The first question concerns a 48-year-old man who was admitted for an endoscopic retrograde cholangiopancreatography, ERCP, for a common bile duct stone. He was given gentamicin and piperacillin to cover the procedure, but he still developed an E. coli septicemia. During that time, he was systematically unwell with fever, hypotension, his blood pressure down to 88/50, and a tachycardia. He was treated with intravenous cefuroxime. His pre-procedure bloods showed normal renal function, but 4 days afterwards he remained jaundiced, was afebrile and hemodynamically stable. There was no palpable bladder on examining his abdomen, and his urine output was 40 mils per hour. His blood results, however, showed that he had a urea of 26 millimoles per litre and creatinine of 500 micromoles per litre with a normal full blood count, so he clearly had developed acute kidney injury. So the question is, which one of the following treatments for his acute kidney injury is best supported by clinical evidence from current research trials? And the 5 options are low-dose dopamine infusion. Second one, low-dose dopamine plus high-dose furosemide plus mannitol infusion. The third one, low-dose dopamine plus high-dose furosemide infusion. A fourth one, high-dose loop diuretic furosemide on its own. And the fifth one, none of the above. So I'll just give you a moment to think through the answer to that one. So the answer to this is none of the above. And if I can just explain that, there is no randomized controlled trial evidence that shows that dopamine is of any benefit to renal functional or survival output in patients with acute kidney injury. We expect that this patient has got acute kidney injury that's secondary to acute tubular necrosis in this instance. Dopamine, at best, can act as a pretty expensive diuretic, so it can convert oliguric acute kidney injury into non-oliguric kidney injury. The same really applies for the loop diuretics, furosemide, bumetanide. They similarly can convert oliguric into non-oliguric AKI, but they're of no survival advantage in terms of kidney function or in terms of the patient's survival. So I'd now like to consider various aspects of acute kidney injury, talk about definition, epidemiology, etiology, investigation, the differentiation between ATN and pre-renal uremia, treatment and outcomes. So what is the definition of AKI? Perhaps the simplest and currently used definition is an increase by 1.5 times in the serum creatinine from baseline, occurring over a short period of time, such as hours or days. There are various classifications that we now use. The best known of these is one called RIFLE. Now, this particular acronym defines risk, injury, failure, loss, and then end-stage renal disease, so progressively worsening AKI. And the various categories are based upon the level of serum creatinine and the urine output. When we come on to consider the epidemiology of acute kidney injury, we realise how common it actually is. So 5% of hospital admissions can be complicated by AKI. In terms of the patients who are sick enough to be managed on the intensive care unit, at least 30% of these will receive hemofiltration for AKI. The condition is increased significantly in the elderly. So with patients aged over 80, the frequency is around 1,000 cases per million per year, whereas in patients aged, say, under 50 years, that incidence might only be 10 cases per million. There's no doubt that the presence of comorbidity increases the risk of AKI. In terms of etiology, by far the commonest cause is ischemic, and by that we mean some form of renal hypoperfusion, accounting for perhaps 70%. The histological corollary of that is acute tubular necrosis, which I'll be saying a little bit about later on. 15% of cases are associated with acute glomerulonephritis, perhaps most commonly vasculitis, ANCA-positive vasculitis. Obstruction might account for 5%, drugs and other toxic substances 5%, and then a miscellany of other causes such as hemolytic uremic syndrome and myeloma accounting for the remaining 5%. In terms of basic investigations, we must never forget to perform basic urinalysis, looking for example, blood and protein. If the presence of the latter really suggests that the underlying cause might be an acute glomerulonephritis. All patients who have unexplained AKI, and by that I mean where the clinical history doesn't give the clue, they require a renal tract ultrasound scan. First, to define whether the patient has 2 kidneys, the size of those kidneys, and also to exclude obstruction, which I'll be saying something about later on. In selected cases, a renal immunological screen would be performed, and within that we would expect to perform a serum ANCA, anti-GBM antibody, and an immunoglobulin electrophoresis, as well as ANF. Again, in other cases, which is selected upon the clinical presentation, we might be performing urinary myoglobin estimation and measuring the levels of certain toxins, e.g. salicylate. In patients in whom we suspect an acute glomerulonephritis or possibly an acute interstitial nephritis, we would undertake a renal biopsy. As I mentioned before, the commonest cause of AKI is ischemic renal injury. Within this, we recognize a spectrum in which some patients actually have very early damage without tubular necrosis. These patients are termed as having pre-renal acute kidney injury. It's possible to actually differentiate them from the patients who actually have established ATN by looking at the urinary electrolyte concentrations. In pre-renal ischemia, the kidney is still functional, and because of the ischemic injury to it, the kidney is responding by releasing renin, which leads to formation of angiotensin, and then aldosterone, which of course claim back sodium from the urine, particularly from the proximal tubule, and then distal tubule with aldosterone. This leads to a reduction in sodium concentration within the urine, and also the formation of a very highly concentrated urine with a high osmolality. However, in ATN, established ATN, the renal tubular cells are not responsive in this way, and so the urinary concentration of sodium is greater in ATN, such as more than 40 millimoles per litre, whereas as you can see on this slide, in pre-renal uremia, the sodium concentration is low at around 20 millimoles per litre or less. In addition, the urine to plasma osmolality is different in the two conditions, as you can see, with it being low in ATN, the ratio being high in pre-renal uremia. This next slide shows the histology of acute tubular necrosis. There is a mitotic cell, and this is the hallmark of ATN with tubular cell regeneration. In the middle of the picture, you can see a tubule in which the tubular cells are swollen, some of which have broken off the tubular basement membrane and have blocked the renal tubule. When we go on to consider the treatment of AKI, fundamentally we need to optimize the volemic state of the patient, and that is true of whatever the cause of the AKI. We should maintain blood pressure, monitor fluid balance very accurately, and where necessary, depending upon indications, perform hemodialysis or hemofiltration. Now, we also need to carefully consider the best place to manage the patient. Some can be managed on the renal ward, especially those with single organ AKI, but others need to be managed on the HDU, and those patients with multi-organ failure should be managed on the intensive care unit. Further specific treatment will depend upon the cause. So, for example, patients with vasculitis would be treated with steroids and cyclophosphamide, and possibly plasma exchange, which is also relevant for patients with hemolytic uremic syndrome or TTP. When considering prognosis, first of all, survival, those patients with multi-organ failure who are managed on the ITU have the worst prognosis, and their survival actually depends upon the number of organs that are affected in the multi-organ failure. So, for example, a patient who has 2-organ failure, kidneys and respiratory failure, might have a survival of around 70%, whereas those patients with 4-organ failure have a very poor prognosis indeed, with survival of only maybe 10%. For isolated acute kidney injury with no other organ failure, we're looking at a 90% survival. When we go on to consider the renal functional outcome of acute tubular necrosis, we can expect a full recovery of renal function in approximately 50% of surviving patients. Around 40% of patients will remain with CKD and 10% with end-stage renal disease, which means that they have to have renal replacement therapy after their episode of severe acute kidney injury. The outcomes in other types of AKI, such as with vasculitis, really depends upon the underlying cause. So let's now go on to consider the second question. An 18-year-old girl presented with a 3-day history of fever, abdominal pain, diarrhea and vomiting. She had returned from holiday in Morocco 1 week earlier. She has no significant past medical history and she was well while on holiday. On examination, she is unwell and slightly jaundiced. There is no lymphadenopathy and abdominal examination was normal. Temperature was 37.8 degrees centigrade, blood pressure was 98/56, she had a pulse of 110 per minute regular and her GCS was 15. So when we consider this lady's lab investigations, the key abnormalities that you can see on this slide are that the hemoglobin was low at 6.9 grams per DL, her platelet count was very low at 22 times 10 to the 9 per litre, she had a slightly elevated reticulocyte count, and her blood film showed multiple fragmented red cells. The creatinine was elevated at 350 micromoles per litre, and she had a high bilirubin of 58 micromoles per litre, whereas the other liver function tests were normal. She had a slightly high LDH as well. So the question is, which one of the following is the most likely underlying diagnosis? So from this list of possibilities, the 2 possible answers would be A, TTP, or D, hemolytic uremic syndrome. But with the history of the prodrome of diarrhea, hemolytic uremic syndrome would be the best option. So let's go on to consider hemolytic uremic syndrome in more detail. Children aged under 4 years account for perhaps 90% of all cases, but the condition, as we saw in the case, does occur in adults. We tend to divide HUS into 2 main categories: D+, or diarrhea associated, which are also known as typical cases, and they tend to occur in epidemics, or sporadic cases, which are called D- cases, which are either familial or atypical. Now, HUS has an underlying pathogenesis of microangiopathic hemolytic anemia, or MAHA, and this is what leads to the anemia and red cell fragmentation and platelet consumption. TTP has a similar pathogenesis, and so sometimes it's quite difficult to distinguish between the 2 conditions. The prognosis of HUS is worse in adults and also in the atypical cases, which can be relapsing, and some of these progress to end-stage renal disease. Specific therapeutic options for HUS include fresh frozen plasma infusion and plasma exchange. This figure shows the typical renal histology of HUS or TTP, but of course we would rarely perform a renal biopsy in the patients because of the thrombocytopenia. But this demonstrates intraglomerular thrombi. You can see those within the capillary loops in the glomeruli. A third of the cases of HUS are associated with verotoxin producing E. coli, as was the case in the history that we discussed. When we discuss atypical HUS, as mentioned, some of these are familial cases and they can be associated with deficiency of complement factor H, which is a regulator of the alternate pathway for complement. Deficiency is associated with uncontrolled complement activation with resulting intravascular hemolysis. So let us now consider the third question. A 65-year-old man with no significant previous medical history presents to the GP with symptoms of an upper respiratory tract infection for which he is prescribed a 10-day course of amoxicillin. Towards the end of the course of antibiotics, he comes back to the GP complaining of increasing nausea, anorexia and shortness of breath. He has a blood pressure of 145/95 and he has a new diffuse rash over his groin and thighs. These are the initial investigations which show a hemoglobin of 13, a normal white count, a potassium of 6.8 millimoles per litre, and the patient has got acute kidney injury with a creatinine of 430 micromoles per litre. So I'll now give you a moment to consider the question, which is which one of the following is the most likely cause? So the only realistic answer here is B, acute interstitial nephritis. This gentleman was given antibiotics and then 10 days later develops acute kidney injury and a skin rash, which would be a fairly typical clinical scenario. Just possibly he might have Henoch-Schönlein purpura, but again the clinical history would certainly not be typical of that. This slide shows the histology of acute interstitial nephritis, which would be the cause of the AKI in this case, and you can see the dense infiltrate of lymphocytes and also within the slide eosinophils, which would be typical of AIN. On the other hand, this is a histological picture of a sarcoid granuloma with associated acute interstitial nephritis, and this is a rare cause of acute kidney injury. When we go on to consider the etiology and treatment of AIN, most cases are in fact idiopathic, so no known cause, but quite a few are drug-related, such as in the case with penicillins or loop diuretics, and over the last decade we've seen several cases associated with the proton pump inhibitors such as omeprazole. It is well recognized that viral infections such as the hantavirus can lead to AKI due to acute interstitial nephritis. When we go on to consider the treatment of AIN, firstly we should withdraw the possible causative agent. In this case it was the penicillin. Thereafter, steroids can be used in selected cases. Many of the patients so treated actually recover renal function fully. Let's now go on to consider the fourth question. A 72-year-old man presents with vague right loin pain, nausea and vomiting, and anorexia which has increased over the past few weeks. He has a history of hypertension, managed with ramipril and amlodipine. On examination he looks unwell. His blood pressure is elevated at 162/85, and he has bibasal crackles on auscultation of his chest. There is tenderness on palpation in the right renal angle. Basic investigations show a slightly reduced hemoglobin at 10.9 grams per dl, slightly elevated white count, a potassium of 6.1, and again he has AKI with a creatinine of 392 micromoles per litre and urea of 24 millimoles per litre. An ultrasound scan of the renal tract was undertaken, demonstrating an enlarged right kidney with dilatation of the right proximal ureter. The left kidney was shrunken and scarred. The gentleman had a urinary catheter in situ, but only 40 mils of urine was present in the catheter bag, and there was blood detected within this. An ECG showed no acute changes. Which one of the following is the most appropriate intervention to relieve this gentleman's renal failure? And I'll give you a moment to consider that. So clearly this gentleman has AKI. The correct treatment will be a right percutaneous nephrostomy in this case. You'll recall that he has a dilated right renal pelvis and proximal ureter, and this implies that the level of obstruction is somewhere lower down in the right ureter. This series of ultrasound scans shows the normal picture of the kidney in the top right. On the left you can see the picture in CKD where there is reduced corticomedullary differentiation and increased echo brightness, and in the bottom right you can see the picture of obstructive uropathy with dilatation of the calyces within the kidney. So acute obstruction of the urinary tract must be excluded by ultrasound scanning in all unexplained cases of AKI. The level of obstruction gives the clue to the etiology, and often we require involvement of the urologists to help us in the management of these patients, as they may go on to require cystoscopy as further investigation and also possibly CT urography. If the obstruction is complicated by urinary sepsis, then immediate relief of this obstruction is essential to prevent both systemic sepsis and high risk to the patient, but also to try to preserve renal function. Those cases of obstruction associated with sepsis which are left untreated will lead to rapid loss of renal function, which can be irreversible. The fifth question concerns a 62-year-old man who was referred to the emergency department and required urgent review. He had a past history of CKD, and on this occasion he complains of increasing shortness of breath. His blood tests reveal a creatinine of 570 micromoles per litre and a urea of 48 millimoles per litre. He's anemic with a hemoglobin of 8.9 grams per dl. On examination, he has a pericardial rub and there are bibasal crackles consistent with fluid overload. So you're asked, which one of the following represents the best treatment option in this patient? The only correct answer here has to be C, which is urgent hemodialysis. This is a gentleman who has significant hyperkalemia, but also acute pericarditis due to uremia and pulmonary edema due to fluid overload in AKI. All of those three parameters require urgent hemodialysis. And this slide shows the 5 indications for urgent dialysis in AKI. Severe uremia, so if a patient is vomiting due to their degree of AKI, or worse still, has encephalopathy, then that is mandatory that dialysis is undertaken. When the serum potassium is in excess of 6.5 millimoles per litre, or at lesser degrees of hyperkalemia if there are ECG changes, then that is another indicator of the need for urgent dialysis. Severe acidosis, in other words pH of less than 7.1, would be another rationale for urgent dialysis, and we've mentioned uremic pericarditis and pulmonary edema. So the last case presented with acute on chronic kidney disease, and in the remainder of this lecture we'll be considering CKD, chronic kidney disease. I'll say something about the epidemiology, the etiology, how we differentiate CKD from acute kidney injury, say a little bit about eGFR calculation, how we slow progression of CKD. We'll talk about the endocrine complications and say a little about renal replacement therapy. This is the current classification of CKD that we use in clinical practice. You'll see that CKD is divided into 5 stages, dependent upon the GFR. In the first 2 stages, the patient has a very well preserved GFR, but they're classed as having CKD if they have additional evidence of kidney damage, such as some abnormality of urinalysis or structural abnormality as evidenced on an ultrasound scan, for example, cysts in polycystic kidney disease. You'll see that stage 5 CKD is in fact end-stage kidney disease with a GFR of less than 15. On the extreme right of the slide you can see the relative prevalence of these different stages in the Western adult population. So CKD stage 3 is very common indeed, approximately 5% of adults being affected with this condition. Whereas with stage 4 only 0.2% are affected, and stage 5 less still, 0.1%. When we consider the causes of progressive CKD, diabetes is first in terms of etiology, accounting for 25%. Hypertension accounts for 15%, chronic glomerulonephritis 15%, and then chronic pyelonephritis, obstruction, post-acute kidney injury, and polycystic kidney disease account for 10% each. When considering the formulae that we use to estimate GFR, all UK laboratories use the MDRD formula, which is shown at the top of this slide, and this involves knowledge of the patient's age, sex, and serum creatinine. The Cockcroft and Gault formula is a long-established estimate of GFR, which also takes into consideration the weight of the patient. So how can we differentiate CKD from AKI? Perhaps the most robust way is to look at kidney size at imaging. Those patients with small kidneys definitely have CKD. Other parameters are anemia, which is far more common in CKD than patients with AKI, and also if there is established bone disease already present, then it must mean that the kidney disease has been present for many months before that. Patients with CKD are also able to tolerate higher levels of urea and creatinine than patients with AKI, in whom the changes have occurred very quickly. Loss of GFR is an independent risk factor for cardiovascular events and mortality, as demonstrated in this slide, which shows on the right-hand side that patients with a GFR of less than 15 mils per minute had something like 18 times the risk of cardiovascular events and mortality compared to patients with GFRs of greater than 60 mils per minute. And this data derives from the Kaiser Permanente population around San Francisco. This slide emphasizes the severe cardiovascular mortality of patients on dialysis. It's a logarithmic scale for mortality, and it demonstrates, first of all, that 25-year-olds on dialysis have something like 100 times the risk of mortality compared to a 25-year-old in the normal population. And even similarly starkly, they have the same mortality risk as an 85-year-old in the general population. So you would think that with the increased cardiovascular risk of our patients with CKD, and especially those on dialysis, that treatment with statins would make a big difference to their outcome. However, the trials that have been performed so far, particularly those in dialysis patients, have not shown this to be the case. So the 4D study was published in 2005, and this involved 1,255 dialysis patients with diabetes who were treated either with atorvastatin or placebo, and you can see that the outcome of cardiac death, non-fatal heart attack or stroke was no difference between the two groups. So we now understand that in CKD populations, non-traditional risk factors for heart disease are at least as important as traditional risk factors. The traditional factors being hypertension, genetic predisposition, smoking, diabetes, and hypercholesterolemia. So in addition, we are now looking at the non-traditional factors such as hyperphosphatemia and increased PTH, low vitamin D levels and inflammation as also playing a very important role. Vascular calcification is a particular problem seen very frequently in patients with CKD. When we consider the pathogenesis of vascular calcification, we have to understand that we have natural inhibitors in our system, such as phetuin and matrix GLA protein, and these are trying to counterbalance the parameters that are trying to induce calcification, such as hyperphosphatemia and increased calcium intake, low vitamin D and PTH. In advancing CKD, the natural inhibitors of calcification are reduced and the promoter parameters are increased, and hence the balance is tipped in favour of calcification. When we consider the risk factors for progression of CKD, the two main ones are hypertension and higher levels of proteinuria. In diabetics, there is some evidence that optimizing glycemic control can help slow progression. This slide shows the importance of hypertension in predisposing to progression. The horizontal axis shows mean arterial pressure and the vertical axis drop in GFR per year. You can see that the studies containing patients with well-controlled blood pressure, particularly those top two on the left-hand side of the slide, demonstrated a slow decline of loss of GFR per year, whereas the patients in studies with very poor blood pressure control were rapidly progressing with GFR declines of 8 to 10 mils per minute per year. When we go on to consider the treatment of CKD, first and foremost we must control blood pressure, and the generally accepted target for treatment is now 130/80 or below. The mainstay of therapy is renin-angiotensin blockade in the form of either ACE inhibition or angiotensin receptor blockers. We need to reduce proteinuria, and that is brought about by blood pressure control and the use again of renin-angiotensin blockade. Statin therapy may be indicated for patients with diabetes, for those with established cardiovascular disease, or those who have a high risk of cardiovascular disease according to the normal calculation in primary care. In addition, because of the other competing risk factors for cardiovascular disease, attention to phosphate control and anemia management is also important. Now, the kidneys work as endocrine organs, and there are three particular systems that are involved. Firstly, the renin-angiotensin aldosterone axis. Secondly, erythropoietin is secreted by the kidneys. And thirdly, mineral and bone disorder can come about because of perturbations in PTH release and also the effects of phosphate and calcium. We'll be considering the latter two endocrine complications shortly. When considering the treatment of end-stage renal disease, when patients develop end-stage, 10% of them will opt for conservative therapy. In the patients who progress to needing dialysis, 75% of all UK dialysis is now hemodialysis and 25% peritoneal dialysis. We now have a big emphasis in fashioning arteriovenous fistulae in advance of patients commencing hemodialysis, because we're aware of the detriment to patients' health associated with too frequent use of intravascular catheters, because these can be complicated by infections, recurrent use of antibiotics, and then we have complications such as MRSA and Clostridium difficile infections. Of course, renal transplantation is an excellent option for management of end-stage renal disease. Approximately 40 patients per million per year receive a renal transplant, but we must consider that in the context of the fact that 120 million per year actually develop end-stage renal disease, so perhaps only 1/3 of the patients who may be commencing dialysis programs are actually receiving renal transplants. Let's now consider a sixth question. A 68-year-old man comes to the renal clinic as a GP referral. He has a long history of hypertension, which is managed with ramipril and amlodipine, but most recently he's complained of increasing tiredness. The GP ran some blood tests and he was very concerned about the results. The patient was anemic with a hemoglobin of 9.9 grams per DL, and the patient had CKD with a creatinine of 305 micromoles per litre and the ferritin well preserved at 130 micrograms per litre. You plan to treat this patient with an erythropoiesis stimulating agent, or EPO. Which one of the following would be the most appropriate hemoglobin target for such treatment? I'll give you a moment to think about that. We now believe that a target of 10 to 12 grams per DL is appropriate for the correction of CKD-related anemia with ESA. So previously we had a nice target of 10.5 to 12.5 grams per DL, and this was matched by European anemia CKD guidelines. There's been a new proposal that the hemoglobin target be slightly reduced to 10 to 12 grams per DL on the basis of recent trials, one being the TREAT study, which showed an increased risk in patients with CKD whose hemoglobin was treated to higher levels, the increased risk being associated with CVA and even slight cancer excess. European best practice guidelines suggest that all patients receiving ESAs should be iron replete. We aim for a target ferritin of greater than 100 micrograms per litre in non-dialysis CKD and 200 to 500 micrograms per litre in hemodialysis patients. Patients should have a transferrin saturation in excess of 20%. Any less than this might indicate functional iron deficiency. It's often necessary to provide the iron in the form of intravenous therapy for our CKD patients. What we do know is that correction of anemia has many benefits, as evidenced in this slide, and some of the most important of these are an improvement in quality of life, exercise capacity, improvements in cognitive function, depression, sleep patterns, and sexual function, and there is an important reduction in transfusion need. Now, the final question in this section concerns a 54-year-old man who has CKD managed with peritoneal dialysis. He has been receiving this for 3 years and he has a history of long-standing type 1 diabetes. On examination in the clinic, his blood pressure is 152/84, his pulse is 70 and regular, and there are no unexpected findings. So when we go on to look at the biochemical and hematological data in this patient, we can see that he's slightly anemic with a hemoglobin of 10.4 grams per DL. Creatinine is 480 micromoles per litre, but he has a high calcium of 2.85 millimoles per litre, a high phosphate of 1.8 millimoles per litre, and PTH, which is increased 7-fold above the normal range to 477 pg per mil. So the question is, which one of the following therapies would be most appropriate in this particular clinical circumstance? So this patient has hypercalcemia, he's got advanced secondary hyperparathyroidism, and also a high phosphate. Out of all the options listed, perhaps the best treatment here would be cinacalcet. Cinacalcet will not only lead to a reduction in PTH, but it also reduces the serum calcium and phosphate. Let's go on to consider this syndrome of CKD-MBD, which stands for mineral and bone disorder. We're aware that elevated serum phosphate is associated with increased risk of death in dialysis populations, as evidenced in this slide, but also in non-dialysis CKD populations. The basic pathophysiology of CKD-MBD involves an elevation in phosphate that develops during the decline of GFR, low levels of 1,25-dihydroxyvitamin D, because of course the kidney is the main source of the 1-alpha hydroxylation of vitamin D. Normally the 1,25-dihydroxy-D would lead to reabsorption of calcium from the gut, but as levels fall, calcium levels are therefore low. So we have three factors: a high phosphate and a low calcium and vitamin D, which both feed back to the parathyroid glands, leading to release of PTH. PTH stimulates osteoclasts, which lead to demineralization of the bone, with calcium and phosphate release into the circulation. This slide shows a classical old X-ray showing the rugged Jersey spine of renal osteodystrophy. So our current views on the management of CK-MBD focus on phosphate lowering with diet and phosphate binders. We try to minimize the calcium intake so that patients shouldn't be receiving more than a gram per day of elemental calcium in the form of phosphate binders. We frequently use vitamin D products such as 1-alpha calcidol. The new KDIGO guidance suggests that we should treat rising trends in both phosphate and PTH. The calcium sensing receptor agonists, of which cinacalcet is the only example, or vitamin D receptor agonists can be used for marked cases of hyperparathyroidism. Parathyroidectomy is reserved for resistant cases which are unresponsive to other medical therapy. So this concludes our first lecture.